Pulse field ablation, although non-thermal, has its own effects. You may have heard about hemolysis, coronary spasm, or incidental heating around the electrodes. PFA can cause hemolysis, but the degree to which it causes hemolysis is very system-specific. Hemolysis is caused by red blood cells being electroporated by the field surrounding the ablation electrodes. If too much hemolysis occurs, then you can get too much free hemoglobin in the serum, and that can be toxic to the kidneys, which can lead to renal failure. The degree of hemolysis is related to the size of the catheter, the portion of the catheter that is exposed to the blood pool, the size and magnitude of the electrical field based on the catheter design, and the PFA system's waveform. Now, a lot of people say, but IV saline can dilute the problem, correct? Well, not really. It does not eliminate the release of hemoglobin into the serum, so there is likely still some subclinical renal damage that is occurring. Furthermore, if we have to give 2 liters or more of fluid prior to every ablation case, that is taking us back to the days of Foley catheters and diuresis post-ablation, which we left behind more than 10 years ago. And this is certainly not tenable for either older patients or patients with heart failure. Musculoskeletal stimulation is also system dependent. Phrenic stimulation almost always occurs with all systems when in close proximity to the phrenic nerve. However, actual musculoskeletal stimulation with every application depends on the catheter size, the field distribution, and the pulse components. In other words, not every system has the same amount of musculoskeletal stimulation. Some have a tremendous amount, while others have hardly any at all. MSK stimulation can cause the release of myoglobin into the bloodstream, and this can also be doubly toxic to the kidneys. Use of paralytics only partially reduces MSK stimulation and does not completely prevent the release of myoglobin. Systems that avoid musculoskeletal stimulation may better enable procedures under sedation. It can reduce patient movement with increased mapping stability and also reduce the need for paralytics. Incidental heating is not only dependent upon waveform parameters, but also electrode design and the number of applications. There is some temperature rise with almost every PFA system, but typically this rise is not enough to cause thermal damage. However, if you over-deliver lesions, there is a risk that you can cause stacking of these thermal insults, and this could lead to thermal damage. PFA systems therefore have adjusted timings in the waveform to avoid heat stacking. This is not just a recharge time, but it is also time to allow the tissue and the electrodes to cool to avoid thermal effects. Electrode design can also impact temperature rise and microbubble formation. Systems with catheters that have very rounded electrode edges can reduce localized edge effect heating by better dispersing the electrical field. Now, not all PFA systems are the same in terms of unwanted effects. Catheter designs that minimize blood exposure, current leakage, musculoskeletal recruitment, and target deeper lesions are critical for optimal clinical procedures.